નહીં ગુડ આફ્ટરનૂન હવે ગુડ મોર્નિંગના બદલે નીરજે કીધું એમ જસ્ટ પોસ્ટ લંચ અને પ્રી લંચ સેશન જેમ બહુ ડિફિકલ્ટ હોય છે એમ ટાસ્ક તો ડિફિકલ્ટ છે પણ પોઝિટિવ સાઇડ લે તો સ્ટીલ આઈ એમ નોટ ધ લાસ્ટ સ્પીકર. એરવેઝ ટીબી એરવેઝ બાકી બધી થિંગ્સ જોયા પછી હવે આપણે endoscopic intervention તરફ આગળ વધશું. So today my talk is bronchoscopy, an integral tool of modern pulmonology. So this is our institute. We are just completing 1 year of our newer branch. So whoever have not yet visited, they are most welcome to visit our institute. So basically bronchoscopy can be done as a rigid bronchoscope and flexible. Rigid bronchoscopy is now limited to a very few subset of patients, so we'll restrict my talk towards the flexible one. Bronchoscopy is a procedure in which a hollow flexible tube is inserted into the airways to have a look of the whole airways. In my current lecture, we'll see the diagnostic and therapeutic indications of bronchoscopy, and then we'll have a few interesting cases. The most common indication in cases of bilateral lung infiltrates or cavities or nodules, when we are not having any microbiological diagnosis and patient is not improving with our current treatment, then we can do the bronchoalveolar lavage and can sample and can have a microbiological diagnosis, especially in case of Cox or any MDR bacterial pathogens or PCP or atypical mycobacteria. If we are having such kind of radiological findings, then in these cases it is better to have a microbiological diagnosis upfront, because sometimes this patient does not give us time. So in second and third image, mostly these are the reverse halocene, we can say. These are most likely the mucor organism. So if we wait for the antibiotics to work and sometimes time passes, then we may not have a time to diagnose it earlier. So upfront we should go for BAL. Then second indication is for central lung masses. If the lung mass is central, not peripheral, then CT guided biopsy also becomes difficult, and the risk of pneumothorax increases with the CT guided biopsy. And with this bronchoscopy, we can easily go into the airways, and when we can have a bronchoscopic biopsy. So this is the video is showing. We are inserting in our scope into the airways. This is the left main bronchus, and the mucosa of the left main bronchus is extensively studied with these mucosal malignant infiltrates, and we can have a visible diagnosis also, and we can easily take the biopsy and can sample it, and in few days we can have a tissue diagnosis. This is how we can take biopsy. Then this is also important for biopsying the upper airway lesions. In these cases, we can easily insert our bronchoscope via nose or mouth into the upper airways, and from the vocal cords or pyriform fossa or any other supraglottic mass, we can easily go there and take a biopsy. In this case, we need not give a general anesthesia, and we can do it as a daycare procedure, and we can discharge the patient in a few hours only. So this is a video showing the growth in the supraglottic area involving the area epiglottic fold. The vocal cord is not involved in this case, and this is large growth is seen, and we can easily biopsy like this. So it is very easy procedure. Then to take a transbronchial lung biopsies, in many cases of diffuse lung disease, I can say many ILDs. ILD is not a general term. There are many types of ILDs, and we mostly need to differentiate whether they are fibrotic ILDs or non-fibrotic ILDs, because differentiation is that's why important, because if we categorize, if the fibrotic ILDs are there, they need only antifibrotics, and the non-fibrotic ILDs are they need immunosuppressants, and they can have a very good result with the immunosuppressants. So we can differentiate them using the transbronchial lung biopsies. In many infections also, such as miliary tuberculosis or any fungal or PCP, we can take the transbronchial lung biopsy and can diagnose it. In many fungal infection also, sometimes the BAL does not give us, culture does not grow the organisms. So in these cases, if we have taken the transbronchial lung biopsy along with the BAL, then even if the culture does not grow the organism, biopsy give us the hint. In malignancy, in cases of especially in the bronchoalveolar carcinoma, where radiological finding looks like a consolidation, they generally present as a non-resolving pneumonia kind of things. The second CT image which was showing, it looks like an infection, but in such cases, sometimes CT guided biopsy also does not give a diagnosis, but in these cases, transbronchial lung biopsy give us better. Then in case of mediastinal lesions, mediastinal lymph nodes or any other lesions, or especially in the cancer staging, we can do the TBNA, which is transbronchial needle aspiration, either conventional or EBUS. We generally passes the scope in the airways. We go towards the lesion and we put a needle through the bronchus and can take a sample. While in the conventional, we do it blindly, just like how shown in the last image, conventional TBNA. While in EBUS, there is a separate bronchoscope which have a ultrasound probe with it, and we can see the ultrasonographic view of the surrounding structures, and we can sample it under vision. Diagnostic indications are for taking BAL, biopsies, transbronchial biopsies, TBNA, as I have told. For other indication is in cases of unexplained hemoptysis. If CT is not showing any lesion, or there is unexplained hemoptysis, we can diagnostically do the bronchoscopy. There we can identify some foreign bodies or any endobronchial lesion, and we can locate the site. Therapeutic purpose, it has also a limited role in hemoptysis. We can control the hemoptysis while using the cold saline or balloon tamponade. But in cases of massive hemoptysis, sometimes we doesn't have a vision, so it has a limited role in massive hemoptysis. And then in cases of persistent unexplained cough, there can be some many endobronchial lesion or foreign body or tracheomalacia or any fistulas we can diagnose. Then in voice issues, chronic hoarseness of voice, we can see the vocal cord function and we can diagnose it. Then post-intubation evaluations, in cases of difficult intubations, we can check the endotracheal tube position after it. And in case of prolonged ventilation, when patient becomes tired from any respiratory issues, we can check whether there is tracheal stenosis or there or not. Then in cases of the lung collapse, lung or lobar collapse, we can see there if there any endobronchial lesion is there or not. And in any unexplained wheezing, particularly localized wheeze, sometimes has the endobronchial lesion. Then the therapeutic indications of bronchoscopy. The most important indication is the removal of foreign bodies. We can remove the foreign bodies using various accessories depending on the type of the foreign body. We can do it in most of the time under the conscious sedation only, and can discharge the patient in few hours only. So it is the most rewarding therapeutic indication of bronchoscopy. Then in cases of the lung collapse because of any mucus plugs, especially the chest trauma patients or in stroke patients, generally the respiratory movements becomes decreased. So many a times the mucus secretions remains there and it causing the lung damage. So we can remove the mucus plug using the scope. Then in difficult intubations, especially in cervical spinal injuries or patient is having severe submucous fibrosis, we can easily do the nasal bronchoscopic intubation. Then airway clearance, removing the blood clots or thick mucus, especially in the tracheostomized patients when suddenly they start desaturating. Then sometimes there may be the local aggregation of these clots or mucus, which we can remove it easily. Then tumor debulking, large airway masses causing ventilatory compromise, we can debulk them using various lasers or cryotherapies. In cases of benign tumors, we can remove it totally using the therapeutic bronchoscopy. Then in cases of airway stenosis, we can do the CRE balloon dilatation. We can place the metallic or silicone stents in many cases of these tracheoesophageal fistulas or strictures or any esophageal lung masses compressing the airways. Then in cases of BPF, in cases of persistent bronchopleural fistula, we can do the bronchoscopy and identify the segment which is causing the from where the fistula is there by inserting various dyes and all that, and we can manage it with using various devices. Special indications, bronchial thermoplasty, bronchoscopic lung volume reduction, whole lung lavage for pulmonary proteinosis, and hemoptysis, as I have discussed. Now we'll quickly move towards the cases. Case 1, there was a 35 years female having no comorbidities, no any significant past history. She presented with a history of cough with expectoration and low grade fever since 10 to 15 days. No any weight loss. She consulted a family physician, done a chest x-ray which was showing this right lower lobe consolidation. Her lab reports was showing slightly raised CRP and total counts. Have taken the antibiotics for 7 days and then they came to us. Not much improved clinically with the same symptoms. Done the chest x-ray again, which was showing slightly raised opacity. and so advised her the sputum reports and CT. Sputum was showing the AFB was negative, gene expert negative, and culture didn't grow anything. This was her CT where it was showing the right lower lobe dense consolidation with air bronchogram. So it was a kind of infective etiology. So we straightforward posted her for a bronchoscopy with BAL, because here it was not she was not fitting clinically in bacterial, and she was not fitting radiologically in Cox. So I had to identify the organism was of importance. So did a bronchoscopy, there was no any endobronchial lesion. BAL reports suggest ZN negative, pyogenic culture didn't grow anything. Gene expert show MTB detected with low bacterial load, and rifampicin was sensitive. AFB culture was also sent, so started her on 4-drug AKT. On first follow-up after 15 days, she was clinically okay, not much worsened, but LFT was normal, so continued the same AKT. On next follow-up after 1.5 months of AKT, still she was not much responding. No fever, but coughing was still there. X-ray was done, which was definitely not improved, and showing right lower zone as well as left side few infiltrate. We were waiting for the FB culture so that we can have a sensitivity report so that we can modify the. Meanwhile, added quinolones, but final FB culture came negative. Now at that time we need definitely to do something, as patient is not and culture came negative. We have done other reports to rule out other diseases. So ESR, CRP was normal, CA was normal, ANA was negative. So decided to do the bronchoscopy again to take the BAL, and this time to do the transbronchial lung biopsy also. So he was advised TBLB. He was a bit reluctant, but finally they agreed after 10 to 15 days afterwards, after seeing the worsening of this X-ray again. So bronchoscopy with BAL and transbronchial lung biopsy was done. This was her bronchoscopic picture. This is the trachea. Apparently there was no any endobronchial lesions. There were a bit of higher watery secretions were there. Right lower lobe, the lesion was in the right lower lobe, but this is the there was no any endobronchial lesion except for this raised secretion. And then we have taken this transbronchial lung biopsies. In this we generally insert the forceps, we wedge into the identified segment, and we generally do this transbronchial lung biopsy from there. And then report came, gene expert was negative for MTB and TBLB suggestive of adenocarcinoma with lipidic pattern. So it was a basically bronchoalveolar carcinoma. Then she referred to oncologists, have taken multiple chemo, multiple ups and downs, and finally she succumbed after 2 to 3 years. But take home message was there, gene expert is not always specifically when the bacterial load is very low or low. So we should definitely go with the FB culture also simultaneously, and this is how we can take the biopsy. Moving towards the second case, this was a 18-year female, recently diabetic with A1C of 10.2, history of cough with expectoration since 7 to 8 months, with history of dyspnea on exertion, occasional wheezing, no any weight loss. Consulted many physicians, family physicians at periphery. Her IG was slightly raised, sputum AFB was negative, X-ray was normal, CRP was in the range of 10 to 20, was being treated with the antacids considering the GERD as the cause, and also the bronchodilators with the rotacaps. In between she was remaining okay, and sometimes there were bouts of coughing also, so, but not relieved completely in her symptoms. Her past history was fall down from bike 9 months before, had minor trauma only, no admission at that time, CT brain was normal. She had history of left salping oophorectomy 2 years back for large left ovarian cyst. She also had a report of USG 3 months back, which was showing the right complex ovarian cyst also, but no any abdominal symptoms at that time. And this was her X-ray was normal. Then they have done a CT thorax at periphery, and it was showing this well-defined, predominantly calcified area in lower trachea at the level of tracheal bifurcation, query hamartoma. And so she was referred to us for further management. This in CT, definitely there was a lesion at the level of lower trachea, at the level of bifurcation. So first on presentation to me, patient was clinically okay, RS was showing monophonic wheeze, saturation was normal, and so she posted straightforward for a bronchoscopy to see the lower tracheal lesion. And to our surprise, it was this. It was a જુજુબે સીડ બોરનો થળિયો હતો. It was there since 8 months. It was moving from right main bronchus to trachea to left main bronchus freely since these months. And we have tried to remove it initially using the red tooth forceps, but whenever it was removing at the narrowest part of vocal cord, it was slipping again and again. So then finally it was grasped with this Dormia basket. I have grasped it completely and fixed with it, and then removed with this Dormia basket. So it was a case of jujube seed sitting there since few months. Retrospectively, on asking multiple questions, she told that she was eating it at the time of accident 8 months back. So this is how it comes like. એટલે હમણાં ઉત્તરાયણ પણ ગઈ છે, જો બોરના કોઈ વધારે ખાધા હોય બોર તો થોડુંક ધ્યાન રાખજો. So foreign body removal from the airways are the most important and most rewarding therapeutic indications. We have removed many foreign bodies, and in almost half of the cases it was the betel nut. So thanks to the unconditional love towards the mawa chewing of our society, we have removed this metal hook, plastic pin, notice board pin, and many things. So it is most rewarding thing. So we'll quickly take the third case also. There was a 68-year male non-smoker having multiple past histories. History of right-sided cox effusion, taken AKT, no papers available. History of RA with secondary Sjogren in 2009. He was on treatment for around 4 to 5 years, then have stopped treatment due to the, there was no symptoms related to it after it. At that time, RA factor was positive, ESR raised, have taken methotrexate. Known case of DM hypertension since 5 to 6 years. History of left mild effusion again in 2019. It was exudative lymphocytic, ADA negative, gene expert cytonegative. Then he improved with the antibiotics and supportive treatment without steroid, without AKT. But it didn't recur, so have not evaluated at that time. History of bilateral involuntary closure of eyelids since 2 to 3 years, and was diagnosed as a blepharospasms. Multiple neuroconsultations, MRI was normal, acetylcholine receptor antibody was negative. Have treated with the Pacit and Botox injection, Distinone, but nothing worked. But he was now happy with the modified specs, which was lifting his eyelids since around a year. This time he presented with the cough with expectoration since last 2 to 3 months, occasional wheezing, no weight loss of around 3 to 4 kg, no joint pain or no any other systemic symptoms. Consulted at other center. The labs were showing raised CRP, raised TC, started on antibiotics and symptomatic treatment. Have 2 to 3 follow-ups there. But CRP was remaining in the range of 90 to 120 only, even on the treatment. His X-ray was showing this slightly mediastinal widening. He was not improving in lab reports and clinically, so he was referred to us. On presentation to me, he was vitally okay, saturation was normal, ART was generalized, so have done few tests. PFT was showing moderate obstruction with good reversibility. LDH was 130, CE was normal, RA factor was a bit positive, HbA1c was 7.1, so it was also not much worsened, and have done the CECT thorax. This was his CCT, and if you can appreciate, there were enlarged mediastinal lymph nodes, particularly the right preparatracheal and subcarinal and hilar lymph nodes, and they were enhancing on contrast. So there were multiple enlarged enhancing mediastinal lymph nodes, and so he advised to go with the bronchoscopy with TBNA, conventional TBNA, which we are doing, and with ROSE. ROSE is rapid on-site evaluation, where we generally keep the pathologist besides us, and we generally do the TBNA passes and give the sample to the pathologist, and they evaluates in real time, and they give us the idea about the cellularity and the probable diagnosis, so that we can have idea that how much passes we need for the diagnosis. So we have done it. This was his bronchoscopic view. The airways, the trachea was narrowed side by side, suggesting the external compression from the lymph nodes. And this is how we do the TBNA. We insert the TBNA needle. This is the subcarinal area. We insert the needle inside, and we by jabbing method we take a TBNA, just like what pathologists do for the external lymph nodes. And on reports, it showed gene expert was negative, and cytoblock showed discrete and confluent non-necrotizing granulomatous inflammation. either Cox or sarcoid, but in view of no necrosis, sarcoidosis was favored. In 2026, research continues to emphasize that while EBUS TBN is the gold standard for most mediastinal lymph nodes, particularly for nodes less than 20 mm, still conventional TBN remains highly useful and cost effective in resource limited settings, particularly for sampling the larger nodes more than 20 mm and particularly for these locations, subcarinal and peri and paratracheal. It is less expensive, and the sensitivity for malignancy typically approaches 70 to 90%, and on addition to ROSE, we can increase the yield further. In this case, rheumatologist opinion was taken, NTCCP was strongly positive, so RA was definitely there. Montus test was negative, so it was considered as a sarcoidosis with RA and started on methotrexate, prednisolone, plus inhaled bronchodilators in view of the PFT findings. Just had a follow-up few days back. He is doing extremely fine, and to the surprise, his ptosis symptoms also was improved around 30 to 40%. So summarizing the key takeaways, flexible bronchoscopy is a very useful procedure in current practice, and it can be done as a simple daycare procedure. In current era of an evidence-based medicine, there is no role of an empirical AKT, except in few cases of extrapulmonary TB, where we cannot sample it. In non-resolving pneumonia also, if we do the early microbiological diagnosis, then we can save patient from unnecessary higher antibiotics and unnecessary financial burdens. In any unexplained, undiagnosed hemoptysis, chronic cough, or localized wheeze, threshold for subjecting a patient to a bronchoscopy should be low, because many times we find very much surprises within the airways. For example, fistulas or small segmental lesions or foreign bodies which are sometimes missed in the CT. ILD should not be left unspecified and untreated. As I have told, the fibrotic and non-fibrotic ILD should be differentiated and should be treated. In central mass and upper airway masses, we can easily take the bronchoscopy biopsy, as I have showed, and in mediastinal nodes, we can easily sample it with the conventional or EBUS TBN. Thank you very much.